I'm Lisa Tan. Welcome to Oxwide, our Trust News video. Now, electroconvulsive therapy, or ECT as it's known, can be very effective for some patients. We visited Jeck, who manages our ECT service, to find out exactly what's involved. Can you tell us what is ECT and why it's used?
Well, ECT is electrical treatments used for depression, very severe depressions for patients in Oxley's. Yeah.
So what conditions can ECT be used for?
ECT treat conditions like catatonia, psychotic depression and very severe depressions.
And what's catatonia?
Is somebody who gets stuck in a way, they're stuck in one position, they cannot move and they can't communicate with you.
So how does ECT actually work?
What it does is the electrical impulses that we generate helps with stimulates the neural receptors, increase the productivity of neurons in the brain cells.
So a bit like resetting someone's brain?
Yes, yeah.
So are there any different types of ECT?
We use bilateral or unilateral. And bilateral is on the temporal side and unilateral is one side. So if somebody, let's say, has very severe side effects, then we can switch over to unilateral. But we always start with bilateral, yeah.
And what happens to you when you have ECT?
What it does is it stimulates a fit, which will last for a few seconds. So it goes through the phases of fit, like tonic, clonic phase and recovery. And then during the treatment, you're given two drugs. So you're asleep while we're giving the treatments. And you have the anesthetist and the ODP supporting you during treatments. So
you wouldn't feel anything or know anything?
Yeah, you're fully asleep.
And what happens after a course of ECT with patients?
After the treatment, once the patient is started to get alert, then we will transfer them to the recovery room, which we monitor blood pressure, pulse, respiration, oxygen saturation for at least half an hour to an hour until they're fully recovered. And then once they're fully recovered, they go to the refreshment area where they can have a cup of tea or a bit of biscuit before they leave the place. Yeah.
How do patients know if it's worked, if it's taken effect?
Normally, the family tend to be the first one to know, and the patient will know later that they're getting better. So the family will notice, oh, the patient is doing this and that, a bit more involved. And then after 3 or 4 treatments, they realize that they're improving as well. So they're able to do things that they were not able to do before.
Is it likely that you'd need to have a repeat treatment at any time?
Most people will have one course of treatment and then they're discharged and we never see them again. For some patients, they might have maintenance once a week and then once every 2 weeks and then once a month and then discontinue after that.
So is the perception of ECT improving, do you think?
It is getting better in some ways, but we got lots of quite anti-ECT people, so it doesn't help in a sense. But we try our best to explain to the patient the process of it and the pros and cons of the treatment itself. So we got a big leaflets that we go through with the patient, explain to them so that, and the family, so that they can understand what it involves. Yeah.
And there's quite a high success rate, isn't there?
Yes, the success rate is very high. It helps nearly all the patients really, because of the type of the illnesses they're suffering, like depression. So ECT helps a lot with that type of illness.
So it's not like you've seen on TV, the old black and white films
where
they're doing it. It's very, very different to that.
Very different, and patients are encouraged to ask questions before they have the treatment there, and they're encouraged to help themselves to lie down, things like that. So nobody is forcing them to have the treatments. Yeah.
Jeck, thank you very much for your time today.
Yeah, you're welcome. Thank you.
Now, we've just heard the good news that Abi Fadipe is our new medical director. So we caught up with Abi to get her reaction to the news.
So hi Abby, thanks for joining us and congratulations on your new role.
Thank you very much.
Can you tell us how you're feeling about, since you received the news that you're now our new medical director?
I'm feeling quite excited, and I'm feeling very important because the number of people that have emailed me, sent me messages, contacted me just to congratulate me and say how pleased they are that I got the role. So I'm feeling quite chuffed, and I'm feeling probably much more important than I should. But yeah, it's been quite exciting.
That's good. We've all been watching social media. It's absolutely exploded since you had your message out. So what are you most looking forward to about the new role?
I'm looking forward to going out to see teams in my new role. There's some teams that I know quite well and people will know me in those teams, but there are other teams that I will be a new face to them. So I'm looking forward to going around the trust to see people who don't know me, to learn about what people are doing in parts of the trust that I don't know, and giving people the opportunity to tell me what they would like from their medical director. So I'm really looking forward to that. I'm also looking forward to probably meeting some of the patients and service users and their carers that I don't probably come into contact with on a regular basis, just to see how they're experiencing our services and just to get to know them and for them to know me.
Yeah, I think that'd be a really nice approach. I'm sure people really appreciate that face-to-face visits, especially after the last couple of years that we've had. So on the flip side of that, what do you think the sorts of challenges will be that you'll face in your new role?
Well, I always say that I see a challenge as an opportunity. But having said that, we can't move away from the fact that we've spent the last 2 years within a pandemic situation, which is not anything any of us have experienced in our lifetime. And as a result of that, we've had staff who have worked very hard for the last 2 years and are feeling a bit tired. This has also affected people in the general population. There's been an increase in demand on all our services, physical health, mental health, children's services, everything. There's been an increased demand. But I would like us to look at it as something that we can take the bull by the horns and see how we can work differently or become optimistic about how we deliver our services going forward. And that's a message I will be putting across when I go out to see teams that I know that people have found the last 2 years a bit difficult, but there's always light at the end of the tunnel. And I think we should be making sure that that light gets brighter and brighter with whatever we're doing to support colleagues and to support the populations that we serve.
Yeah, I think you're right. And actually, I was about to ask you what your message to staff would be, but I think you've probably largely covered it, unless you'd like to add a personal message for our staff.
I suppose I just want to let staff know that I'm here to serve them, and I can only do that if people let me know what the issues are and what they see as their concerns. But having said that, I do want staff to sort of support me with coming up with solutions for whatever the issues and concerns are. So we sort of develop a kind of collaborative, co-productive, supportive kind of relationship, because I think that's what is going to enable me to be effective in the role, because we're going into a whole different landscape, both from the things I've said and what will be going forward over the next few years. So that would be my message, that we will need to work together, and I'm here to serve the staff and the population.
Thanks very much for joining us, Abby, and all the best in your new role.
Thank you very much, Lisa. Thank you for having me.
And finally, our Greenwich Early Intervention in Psychosis team work with some of our most vulnerable service users in the community. We caught up with lovely Abigail and Gary to find out exactly what they do.
Could you tell us exactly what psychosis is, Gary?
Yeah, so the way that mental health services understand psychosis is that it's a mental illness that involves a loss of contact with reality. So people will experience things like hearing voices. It usually affects how people process information. So it might be that they hold beliefs that they wouldn't usually hold and that other people think are unusual for them, or you can experience different things in the sensory domain, so things that affect the 5 senses. So as I said, hearing voices, seeing things, hearing things, feeling things on your skin, unusual tastes, unusual smells. People might experience the forces of external control, that their body's being taken over. They may feel that there are special messages from the TV or radio. So it just depends really. It's a very individual experience. But our team's task is to speak to people and think about, are they experiencing psychotic symptoms, and if they are, can we offer them any treatment and support?
And can it affect anyone of any age, any gender, any ethnicity?
So I think the consensus is that it does usually affect anybody from a range of backgrounds, different sort of social circumstances, people from different ethnic origins. But we do know that there are some factors that are implicated. For example, people that experience deprivation, social inequality. We know young people from black and minority ethnic backgrounds, particularly young men, are overrepresented in terms of admissions to acute wards. But I think generally there's a consensus that it can affect anybody of any age.
The likelihood of mental health patients also suffering from physical health ailments is that much greater. Why is that?
Mental health clients tend to experience a lot of physical health poor conditions because of the type of the medication that they take. Sometimes that can obviously interfere with their physical health, and tend to have diabetes, high cholesterol, and other physical health issues. So yeah, that's why. And they tend to have, poor living conditions. They don't work. They have less money, so therefore they cannot afford, to buy, the type of food that they would need.
How big is that gap? So what's the gap between life expectancy for someone who's suffering from mental health conditions as opposed to someone who's not?
That can vary amongst our clients. So depending on the geographical area that they're living in.
And your team specialise in the early interventions. Can you tell us exactly what some of those interventions are?
The research tells us that there's quite a critical period in psychosis, in that if you can help people during the first episode and you can help them in lots of different ways, like we've said, there's antipsychotic medication. We know that there's social interventions, so things like helping people with employment, vocation, helping them to feel more socially included, things like CBT for psychosis, psychology, things like carer support, family intervention, working with families to help the family process the experience of psychosis, improves the communication in those families, which helps clients' recovery as well.
Tell me more about your role, Abigail. What do you do within the team?
As a care coordinator within the early intervention psychosis team, is to support clients that are suffering with a psychosis condition. Also to support them to get back to normal life. So some of the things that we would do is offer different interventions, like employment, getting them back into employment again. One of the services that are available is the child and athletic services, and this is quite popular within the community because it gives people an opportunity to meet other people that have mental health illness, and also to get out into the community and visit places that they wouldn't ordinarily be able to do, if that service wasn't available. We also have services like psychological services such as cognitive behavioural therapy that patients will engage with the therapist, And this is to kind of give them an understanding of the illness that they're experiencing, and just help them to have a better understanding of how best they can, move on, and live a normal life again.
If your team interventions are early enough, then it can help prevent some service users from ending up in a more serious sort of crisis, and they're less likely to be turning up at END, which is not the right place for them.
So the aim of our team is to work in partnership with other potential referral sources, so that we're identifying people earlier in their episode of psychosis. Then we can start to work with them, start to introduce treatment, and hopefully that means that we prevent the chance of the illness becoming much more advanced, and unfortunately, resulting in people going to A&E, which are not the ideal environments for people experiencing this kind of mental illness. So the idea is the earlier that we get in there, the much better it will be in terms of their treatment outcome and avoiding additional trauma on what is already arguably a very traumatic experience.
Well, that's it for today. We hope you've enjoyed it, and we'll see you soon.